Let me see if I can start slideshow. Yeah.
Sir, नीचे corner में आइए, नीचे last.
Let's see.
Yes. Yeah, it's okay.
Okay. Sorry for that delay. So I will be talking about whether OCT is adequate. And for the fun part of it, let me say all debates are about semantics. The term adequate, essential, and AMD are key to success in this debate for me, I believe. So, but we will not use the lamest excuse, that is that we're using anti-VEGF, therefore we do not need to do imaging properly. So in AMD, I would like to go beyond the point that it is not just about diagnostics. So we are talking about treatment decisions, responses, prognostication, and modulation. And that is where I feel that OCTA passes where conventional may not be that adequate. So the conditions where a wonderful advantage is derived is CNVMs in the presence of atrophy, response to treatment, and non-exudative CNVMs in AMD. So I'd like to show you this picture. I'm sorry, but I cannot see the pictures very clearly. You see a membrane over here and the corresponding picture. But instead of the FA, what is wonderfully brought out is the exact vasculature of the membrane, which is brought out in OCTA, as you can see in the image over there. So I think all the images are getting overlapped on my computer. So I simply cannot proceed. I'm sorry about that. I think you can see it, isn't it?
We can see it. We can see it.
Yeah, so I don't know what I'm showing on my system.
It's a multicolor image only.
Yeah, I know. I mean,
yeah.
Is that okay? Yeah.
Yes.
I'm sorry for being such a nuisance, but anyway, let me continue. So anyway, this is what I wanted to show the pictures. That it's not a research tool, and eventually we have to integrate research into our clinical practice. So this is a picture of a CNVM here, but this is what you see. You see the perfect vascularity of that membrane. Why do you need to see it? Yes, because it guides your treatment, and you can assess regression also. Here you have a multicolor picture showing the green shows fluid, the red and the dark area shows hemorrhage, and this is how the hemorrhage looks on an autofluorescence and infrared. But and this is what the whole picture looks on an OCT. But the definition that you get, the membrane definition that you get, this unparalleled. You do not get this kind of image on conventional angiography, how big it is, which is a central stem, where is the feeding vessel, how large it is. And all this becomes of relevance when you start treatment and when you watch it regress and go. So this is a blow up of that image also. So again, here, the fluorescence has totally masks the whole image. You do not see any definition over there. Is it good enough to tell you there's a CNVM? Yes, but we are supposed to proceed beyond that level and go beyond it. So this is the area by which you mark, and supposedly a PDT marking how large is your spot size, but this is the exact extent of the image. You can see that there are projections of the vascular net in different sides and different areas, and this is the exact shape where you see anastomosis going around, which is a poor prognostic feature. Non-exudative CNVMs, you see a flat thing, there is no SRF, no features, but when you do an OCTA, you actually see a vascular net over there, which shows it's a non-exudative CNVM with a destiny to become an active CNVM in about 2 years, 22% destiny. So here again, you see a raised lesion. There's nothing, there's no fluid over there, but underneath the lesion, you see a vascular network. So is it a research tool? Yes, it is a research tool that is going to give you a couple of years in advance before you start, a warning before you start worrying about the patient. So this is that non-exudative membrane again. Another non-exudative membrane, a flat retina, but a large quiescent CNVM growing under the retina, which is destined to become an active CNVM with hemorrhage and edema later. So in the presence of RP atrophy, this is a patient with RP atrophy, you know there is some sort of activity, but there is a total masking. You don't see any activity because of the RP changes. The angiography is simply not good enough to tell you what is happening underneath, but the OCTA shows a wonderful vascular net highlighted at this particular position. So these are advantages that are really derived from the OCT angiography. Response to treatment. Here you see a picture of a large filamentous area with anastomotic channels. After treatment, you see that the small anastomotic channels have disappeared and only the large filamentous areas are remaining. And then after some time, you see regrowth. This is what you mean by regrowth. Before the patient has additional fluid, you see that the CNVM is growing back again. These features you cannot simply see in an angiography, a dye-based angiography. Based on the patterns, you have a lacy pattern, a C-fan pattern, a filamentous pattern, and ill-defined or fishnet patterns. And these are the different kinds: the lacy pattern, the medusa head, the C-fan head. But what is interesting is there's a new pattern described called the fishnet pattern, a tightly dense pattern. And why is it important? Treatment response, there is a very poor response to the fishnet pattern on anti-VEGF. So again, good anatomical response is when the filamentous things go good. Poor anatomical response is when the whole network does not go away. And as you say, this is one of our studies where we looked at the fishnet patterns, and after anti-VEGF, it increased in size. So the relevance in treatment response is the ability to do an OCT angiography as often as you want to. Look for anastomotic channels, and you can base your treat and extend just on an OCTA just before your treat and extend policy, and you can see which all patients escape from the treat extend also. This is my last slide I want to show you. This is a picture of an angiography you've done, but then you do an OCT angiography and you see a small membrane hiding in the behind. This is a case of I found it while I just missed it in the previous case. So the advantages is that in diagnosis, it becomes clarity to certain situations, but in treatment response, assessing the type of vascular network and recurrence base of reappearance of vascularity. What I would like to say, and like to say very clearly, it may be a research tool you may consider, but we are going this way. My talk is proof enough, I believe, to say that this is the next big thing that we should invest in to give better care for our patients, no financial considerations. Thank you very much.
Yeah, thank you, Dr. Unni and Dr. Giridhar. I'll hand over to Dr. Muna to decide the winner if there's one in the first debate.
Thank you, Nitin.
Unni is the winner. I don't want to go into, I am 20 years elder to him. So
and Dr. Giridhar is very gracious in that.
Old is gold.
Now you two will meet Muna outside and come back. Both meet Muna outside the hall and come back. She will announce the winner.
Now, I don't know whether I fall into the old category. Yes.
You are neither old nor young. You are in the middle.
Unni and Dr. Giridhar, let me say, are experts in the field. And we have heard from people who probably have the most experience in both the investigations. And what we saw from both of them is the fact that these investigations have a role at different points in time. The advantage of fluorescein angiogram and ICG is something we learned over the years. We know we can identify leakage. We understand the patterns. Everybody understands the patterns. But we also know there are cost constraints. You cannot repeat the test every week or every month like we would do an OCTA. And then because there's a lot of fluid, sometimes we may even miss the lesions. But definitely fluorescein angiogram and ICG, there are selected roles like low flow lesions like Sir mentioned. And as far as Unni's talk is concerned, OCTA is a wonderful research tool. Like everyone, before we gave the vaccine, we wanted proof that the vaccine works. We wanted research studies before we accepted it. So research is essential, and I think we've learned that research has proved that OCTA is invaluable. It has its problems. If all of you noticed in both the talks, they both relied a little bit on OCT as well. So I think the winner of the talk is both the debates is actually OCT, which seems to be common on which is
what I was thinking that, it should be OCT versus something actually, because now I think everyone is treating based on OCT.
But still, I would say OCTA has a role in diagnosis, assessing treatment response, the ability to frequently do the test as often as you want without the patient definitely has a role. But I would say it's evenly, and OCT probably is the winner of this.
Thanks, Muna. She won the diplomacy war, so we go on to the